All right. Thank you very much, Bruce and Tom, and I appreciate the opportunity to speak to all of you here today on what's increasingly becoming an important topic that is a major source of morbidity in our patients, primarily hospitalized inpatients with severe colitis, thromboembolic complications. I'd like to thank these three people, Namazit Amirsky, Menno Verhoeven, and Cameron Trenner at our center, who have actually led the charge on this issue. They've written an outstanding article in the IBD Journal about this topic, much of which I've taken material from, and I would encourage all of you to read it. My overview is going to first discuss the pathophysiology of thrombosis, the risks of venous thromboembolism in IBD patients, both the relative risk and the absolute risk, the risk factors for thrombosis both in the general population and in IBD patients, how one evaluates a suspected thromboembolic event, how one prevents clots from forming, and also how one treats clots once they form. So the first important topic is to distinguish between arterial and venous thromboembolism. Arterial thromboembolism, usually a clot in a small artery like a carotid, a coronary, a superior mesenteric. That's a very dramatic presentation, as I'm sure you know, an acute stroke very often or a heart attack. It's quite rare in younger patients under the age of 40, and antiplatelet drugs such as aspirin actually prevent these. In contrast, a venous clot is a clot that occurs in the venous system. Usually it's in the leg or in the arm, a deep venous thrombosis. These generally are not preventable by aspirin, but they are preventable with anticoagulation, usually heparin or Coumadin. Venous thromboembolism is what we most commonly see in patients with inflammatory bowel disease. So, for those of you that went to medical school, we all got experience with the coagulation cascade. This was a very useful thing for me because after being asked to memorize this, I've decided to go into gastroenterology rather than hematology. And to quickly summarize here, you have a number of clotting factors, 12, 5, ultimately going down to thrombin and prothrombin, and then ultimately you get fibrinogen going to fibrin polymers or clots. The important thing to take home from this particular slide is that in addition to prothrombotic molecules and the coagulation cascade, you also have protective molecules, including protein S, protein C, and antithrombin, which are inhibitors of the coagulation cascade. And if you have either an accelerated production of the clotting factors or a deficiency of these molecules, you're at increased risk for developing thrombosis. Now, how does heparin work to prevent thrombosis? As I showed you in the previous slide, antithrombin, an antagonist of thrombin, binds to it, and what heparin does is it actually stabilizes this bond so that antithrombin sticks to thrombin longer, thrombin is inhibited for a longer period of time, and basically, once you take the heparin away, these molecules can dissociate. So that's how heparin works. So what are the risk factors in the general population for thrombosis? Well, they can include the hereditary thrombophilias, such as factor V Leiden mutation, which is present in 5% of whites, 2% of Hispanics, and 1% of African Americans. There are also prothrombin gene mutations that predispose you to more thrombosis. These occur in about 2% of Caucasians. Or, as I mentioned before, you can have deficiencies of the inhibitors, protein S, protein C, and antithrombin 3 deficiency. There are also environmental risk factors in the general population that are important, including smoking and oral contraceptives, both prothrombotic, and of a lot of relevance to the IBD population, surgery or immobility, being bedridden. Now, why are IBD patients especially at risk? Data suggests the most common factor that predisposes these patients to thrombosis is inflammation and disease activity. And patients, especially with active colitis, have increased fibrinogen, increased D-dimer, and increased clotting factors. In addition to inflammation, though, there are other causes of in IBD that may predispose to thrombosis. These include endothelial damage, antibodies such as antiphospholipid antibodies, higher levels of homocysteine, perhaps due in part to folate or B12 deficiency, and one prothrombotic medication we don't use too much in IBD, but that you need to be aware of. Thalidomide greatly increases your chance of clotting. Relative risk is up to 8. So, as I mentioned, and to just re-summarize, inflammation is the most common risk factor that predisposes to clot in patients with inflammatory bowel disease. And in fact, when you look at children in particular, deep venous thromboses without risk factors are actually very rare in children, unlike adults. So if you look at this nice study published in the New England Journal of Medicine of 82 patients that had clots, only about 5% of children with spontaneous clots had no risk factors. This is not IBD, this is all comers. Many of them had lupus anticoagulants, central venous lines, infection, or inflammatory processes. So let's talk now more specifically about inflammatory bowel disease and venous thromboembolism in IBD patients. The first thing that I want you to know is the relative risk is quite high. Several epidemiologic studies suggest about a 6-fold greater hazard ratio, especially if you focus on young patients. Older patients get clots anyway, but young patients with IBD tend to have greater risk. It's mainly in patients with flares, and it's mainly in patients with colonic disease, either severe Crohn's colitis or severe ulcerative colitis. If you look at all comers, however, the absolute risk for thrombosis is quite low, and this very nice prospective study looked at 2,800 IBD patients that were recruited over a 2.5-year period and followed for several years. Approximately 4% of those patients developed de novo venous thromboembolism. The mean age was 42. These patients were typically treated with long-standing prophylaxis, and if anticoagulation was stopped, the risk of recurrence is high. So what complications can be seen with increased frequency in adults? A nice study recently published in the Journal of Crohn's and Colitis, and it looked at a meta-analysis of approximately 200,000 patients, and they're at increased risk for deep venous thrombosis, pulmonary embolism, perhaps ischemic heart disease. The relative risk is low there, and mesenteric ischemia. So all of these were highly significant in this population. So let's focus now on our experience in pediatrics at Boston Children's Hospital, recently published. And what we noticed, is if you take all hospitalized children, the venous thromboembolism risk is actually quite low, 1 per 10,000 per year. If you look at patients with IBD, it's about 3-fold higher. And if you focus primarily on inpatients, again, looking at this particular group, 58,000 inpatients per 10,000. In IBD hospitalized children, 1.5%, about a 3-fold increase in risk, 8 out of 532. And interestingly, central venous line thromboses were about 5% whether you had IBD or not. So it's a relatively rare problem we're talking about, 1.5%. So why do we worry about it so much? I just want to talk about a case and to emphasize, this really is a major source of morbidity in our population. It usually happens in the sick patients, those at risk for strokes, or those who can get strokes. It often happens at the worst time when you're thinking about colectomy. And to tell this story, here's a young man who was admitted with severe ulcerative colitis. He got 2 doses of infliximab, failed. We were ready to take him to surgery when all of a sudden his legs started swelling. And we did a Doppler ultrasound, and what you can see here was a very large clot in his inferior vena cava. So what do you worry about here? Pulmonary embolism. The other thing you need to worry about, however, is a patent foramen ovale, which could potentially lead to this clot dislodging, going to the brain, and causing a major stroke. And in fact, when we did an echocardiogram on this patient, he actually had a patent foramen ovale. So we had to treat him with an inferior vena cava filter, anticoagulation. Ultimately, a very experienced surgeon was able to do the colectomy after a period of time, and fortunately he did very well, but it could have been a catastrophe. So these kind of things happen at the worst time. So, based on that, should we prophylax patients with heparin? Well, the data suggests that we don't need to do it in outpatients. According to a nice editorial by Jeff Nguyen in The Lancet, prophylaxis would be needed for about 312 person-years of IBD flares in order to prevent one person from developing thromboembolism in the outpatient setting. However, in the inpatient setting, especially in severe colitis, it is generally recommended. It's included in the AGA Physician Performance Measure Set, but according to a recent paper that was done by my colleague, Dr. Sands, and one of his, I'm guessing, fellows or junior faculty, only about 35% of gastroenterologists actually use this particular intervention, despite the fact that an ACG guideline states the following: heparin has an important role in prophylaxis against thromboembolism in patients admitted to the hospital with severe colitis. So if you have a patient with severe colitis, think about prophylaxing. So how do you prophylax patients? Well, if there's no strong family history of bleeding and the patient is under 40 kilos, you can use a milligram per kilo dose of low molecular weight heparin, 0.5 milligram per kilo twice a day. If they're an adult, there are different guidelines, but one guideline suggests just using a single daily dose of low molecular weight heparin. Other people do use twice daily dosing, and I didn't really see any evidence that says twice daily is better than single. So this is what our hematologist recommend. This is what I usually use. And we typically continue anticoagulation in these high-risk patients until either discharge, resolution of colitis, or if they're having surgery until they, they're post-op and they're ambulating. And of course, you have to suspend it during the surgery itself. Now, in children, we have this additional problem we call the ouch factor, and many children don't particularly like getting an extra shot. Many of these patients are getting intravenous IVs, phlebotomy. Do we really need to give this? Well, I will tell you that we have moved to doing this in our children, even as young as 3, and you can actually leave a little indwelling catheter in that will facilitate the subcutaneous administration of heparin. So, what do we do if we have colitis at the time of diagnosis and they're inpatient? We review the family history for thrombosis and bleeding. We address dehydration. Hydration is very important to prevent clots. We address immobility, and we try to ambulate our patients as much as possible. It gets to be a challenge if they're C. diff positive and they're locked in their room, which sometimes happen, but we still try to get PT in there. In women of reproductive age, you can talk about pros and cons of various contraceptive regimens to reduce their risk as outpatients. We counsel about smoking, inactivity, and long travel in our older patients. And we consider working up for hereditary causes or for acquired causes of thrombosis, including factor VIII, D-dimer, lupus anticoagulant, and anticardiolipin antibodies. In adults, it's a little bit simpler because you can pretty much think about prophylaxing most of your adult patients. In our group, we like to think about what are the risk factors. So again, inpatient colitis or major surgery, and we like to review these things: personal history of thrombosis, family history of thrombosis, known hereditary thrombophilia, OCP, smoking, obesity, or having a PICC line in. And any of those, inpatient colitis plus this, makes you a particularly high-risk patient. So let's move on. Let's say you've forgotten to prophylax, or the patient's unlucky and they've gotten it anyway, and you're worried about a DVT. Well, you need to have a high suspicion of DVTs to think about them, because again, these are young patients. You won't always think about it. The most important things to think about are headache or vomiting, which could suggest a sagittal sinus thrombosis, or extremity swelling, especially of the legs, which makes you think about a deep venous thrombosis in the legs. The main lab that's helpful is a D-dimer, and a negative D-dimer has an excellent negative predictive value for absence of a clot. So if you've got a negative D-dimer and your index of suspicion is relatively low, you can stop here. However, if your suspicion is high, of course, you need to go to imaging. Ultrasound is usually our first test. For the CNS, however, either MR or MR venography are preferred. Spiral CT if you're worried about a pulmonary embolism. And don't forget, if you have a DVT, think about a cardiac echo for a patent foramen ovale. How do you treat clots if you find them? Well, this handout here shows the doses. You can either use unfractionated heparin, low molecular weight heparin. Typically, once they get better on these, you may be able to transition to warfarin. And again, in a patient with severe unresponsive colitis who has clots, we seriously discuss the option of colectomy, and we generally recommend it in our patients because we're worried if you have ongoing active disease that does not respond well to your agents, you really have to, may be at risk for recurrent clots. However, the timing of colectomy is tricky. You don't want to do a colectomy in someone who's just flipped a pulmonary embolus or he has a very large DVT. You want to really think about treating first, perhaps with anticoagulation, stabilizing the patient, and then maybe going to colectomy. What additional therapies can be considered? Catheter-directed thrombolysis in certain patients, an inferior vena cava filter. I talked about that with that large IVC clot. This is actually what an IVC filter looks like. It's a very crude mechanism. You've got this little hook up there. You've got this little net. You try to get an interventional cardiologist to stent it past the clot. It opens up and it basically catches clots. If thrombolysis is contraindicated for some reason, you could think about surgical thrombectomy. And then the main question that we all struggle with is a large clot that complicates severe colitis an indication for colectomy? And if it is, and it often is, what's the optimal timing for that colectomy? And our general approach is to try to control the colitis medically if we can, treat the clot, and then think about operating down the road. Is heparin safe in inflammatory bowel disease? Well, I think those of you probably who have been in this field for a decade or more probably remember a paper by Josh Korzenick who actually utilized heparin to treat IBD. And while it's certainly not a standard therapy for colitis, it appeared to be safe without any increased risk of bleeding. And when you look at the data, severe bleeding on anticoagulation is quite rare. So if you look at treatment versus prophylaxis, basically the bleeding rate is about 2 to 3% for each of these. We had one person with severe colitis out of 9 who developed a significant bleed on anticoagulation. We had to stop it, but that was probably going to happen anyway. We don't really know, but the evidence suggests that it's probably pretty safe and that severe bleeding on anticoagulation is rare. Of course, it's a consideration. So, in conclusion, all patients with inflammatory bowel disease are probably at a slightly increased risk of clots, especially during disease flares. But the absolute risk, especially on your outpatients or your mild Crohn's disease, is quite low. The highest risk group appears to be in patients with severe colitis. The main factor that mediates that is probably inflammation, but there are probably other factors including genetic predisposition, immobility, dehydration. And prophylaxis with low molecular weight heparin is indicated in patients hospitalized for severe colitis or post-op. And here I think you can work with your hematologist, figure out what dose he uses. The dose our hematologist used in adults is 40 milligrams sub-Q once a day. And this is a dose that's also in the medical letter. Some places do twice a day. Thank you very much.